Thank you, Dr. Lima. So I'm going to talk about the cardiac MRI overview. It's just a short time or period. So going through is some of interesting cardiac MRI application and going to touch to the little bit about myocardial strain and moving on to the discussion of cardiac MRI strain imaging after my talk. So I'm going to start with the interesting case. I'm going to show you is how important or how effective the cardiac MRI to detect the high-risk patient. So this patient is 75 years old, the effort angina since 2 months ago. It's a little bit long. So this patient is referred to our imaging center from university. As you are a cardiologist, you can see it's based on the EKG, so some biphasic T phase and also negative U wave that is typical for severe myocardial ischemia. And we just scan this patient. The LV wall motion is a little bit decreased, but it's not quite detect any focal asynapse or focal LV wall motion abnormality. It's just a diffuse decrease of LV wall motion. And we can perform stress perfusion imaging here. And you can see it's a perfusion defect. It's from the anterior wall to septum. It's some lateral wall. That may be an implication for the inducible ischemia in the LAD and circumflex area. It's a multivessel disease we can expect. And also, it's a delayed enhanced, late gadolinium enhanced image. So you can see it's a very small, tiny infarction here. As these are the people just see it's unrecognized silent MRI. And we move on to the coronary MRI sequence. It's not many institutions doing, but we are doing. It's so many coronary CTA cases. You can appreciate it's severe stenosis. It's here, left main system. And you can appreciate it's a severe stenosis in left main system. We send this patient to the heart center to get the immediate coronary angiography. It's the same patient, so you can see it's a severe stenosis in the left main system. And under IABP support, patient got the successful stenting without any complication. That is the one. It's example. It's how cardiac MRI can save patients. Then I'm going to talk about cardiac MRI protocol at CBIC and also coronary MRI and the cardiac MRI of myocardial disease, the ischemic, non-ischemic, and also a little bit future is T1 mapping and myocardial strain. So this is a typical protocol at our imaging institution. It's starting from the cine MRI and the T2-weighted imaging, and also it's a coronary MRI. So from here, I think the imaging study can be done very quickly without any contrast agent. Injecting contrast agent to get the perfusion imaging and waited a little bit, a couple of minutes, and get the late gadolinium enhanced image for characterizing myocardial disease. These are typical imaging protocol as we are doing every day. Within 1 hour. And the time is very, very important for cardiac MRI study because the cardiac MRI takes very long. And we have tools to make the cardiac MRI study shorter. The one is the CardioLine. It's a new application from Toshiba, just introduced. And this CardioLine is automatically positioning for LV, get the nice LV positioning automatically. To get a nice result. This is again the automatic positioning that may assist the radiotech can get a nice imaging plane without any difficulty. So how impact is this CardioLine system is that it's one example from Japanese institution. As using this system, it's a full study. It's making the very short. It's a non-contrast study. It's a 23 minutes, and the full study is 47 minutes. That is a very effective system to make the cardiac MRI study shorter. That is very important for cardiac MRI. And also, this CardioLine system is recently upgraded to the CardioLine Plus. This is the next version to get multiple plane, including the RV system and also aortic valve, pulmonary valve. These applications may help to get a nice cardiac MRI plane as for radiotech, and also it's easy to diagnose for doctors. And also, it's another application to make cardiac MRI study shorter. It's a parallel imaging technique. The new technique introduced the KT speeder. So this is the next generation for acceleration system to make the cardiac MRI study shorter. With this system, just one breath, we can get multiple plane of short axis of imaging. It's a very effective system to make the cardiac MRI study shorter. Okay, and I'm gonna move on to the coronary MRI sequence, to how to use the coronary MRI. So this is a study done by Dr. Sakuma's group. They have done a very nice study, multi-center study, just published in 2010. They have done, it's 138 patients from 7 different hospitals. They get a nice result, the sensitivity and the specificity about 80 to 90%. And I want to emphasize it's a negative predictive value, it's 96%. It's very high, it's NPV. It's good for patients, excluding the coronary artery disease for patients. And also, some people believe it's a coronary MRI sequence may work. It's a particular scanner, the particular sequence, but it's not true. So we can get very nice result, a different scanner, the different it's a type of sequence, so we can get very nice result. But unfortunately, it's a coronary MRI is not good for all patients. So we have to select the patient for coronary MRI. As I can pick up, it's a several points for favorable patients. One is a chronic kidney disease, because the coronary MRI doesn't require any contrast injection, so we can use this type of sequence for chronic kidney disease patients. And also, it's a low to intermediate risk patient is good candidate for coronary MRI. And severe coronary artery calcification is good candidate for coronary MRI. And also, of course, it's allergy to the X-ray contrast agent is definitely good candidate for coronary MRI. I'm going to just talk about severe coronary artery calcification. This is data of the coronary CTA of the dialysis patient. It's a severe coronary artery calcification, so you can see. But putting this patient to the coronary MRI, on MRI, there is no signal from the coronary calcium. That's why we can get a very nice result of the coronary artery on coronary MRI. We can compare carefully from left side is coronary CT, and right side is coronary MRI. We can identify the corresponding coronary stenosis on coronary MRI. Again, if patient has a severe coronary calcification, coronary MRI sometimes works very, very well. And unfortunately, a coronary MRI is not good for patient, for example, it's a stent or bypass patient. And also arrhythmia patient, it's very irregular RR risk or rapid AF, frequent PVC, and also very bad respiratory pattern, the sleep apnea syndrome or COPD, and obesity has a very big patient, as more than 100. And contraindication to nitroglycerin is not good for coronary MRI. I'm going to focus on the bad respiratory pattern. And this patient has a severe coronary artery calcification in LAD. We can get very poor coronary MRI. It's a whole heart coronary MRI. The LAD is very suspicious for any stenosis, but we cannot get nice result. We just move on to the breath hold sequence to getting the LAD targeted sequence. We can get nice result of coronary MRI on LAD. There is no significant stenosis at all. Of course, this sequence is relatively long, 25 seconds breath hold. But using this type of sequence, we can get very nice result. And I move on to the myocardial disease of cardiac MRI. To characterize myocardial disease, rate gadolinium enhancement is very powerful tool. And this is a very nice summary. It's a figure as ischemic heart disease and also non-ischemic heart disease. So there is two basic mechanisms. We can see the rate of gadolinium enhancement. The one is acute setting, ruptured cell membrane. We can get the rate of gadolinium enhancement. The other is a chronic setting, the myocardial scar. We can get the rate of gadolinium enhancement from scar. These are basics of the gadolinium enhancement mechanism. Using this rate of gadolinium enhancement, it's large population of the myocardial viability can be assessed by cardiac MRI. This is a very nice study as published by Ray Kim in 2000. It's more than 50% of the enhancement indicate its myocardial viability is very unlikely to recover after the intervention or any revascularization procedure. This is an example of the case of a 67 years old asymptomatic patient. This patient has an EKG change from 2008 to 2009. So you can see the heavy wall motion abnormality, hypokinesis in the anterior wall. This wall has a rate of gadolinium enhancement in the subendocardium. And doing the perfusion imaging, this is a typical pattern of perfusion defect. You can see the anteroseptal segment is a perfusion defect. On stress, but rest, there is no perfusion defect. This indicates it's an active or inducible myocardial ischemia in anteroseptal wall. So on coronary MRI, you can see it's a significant stenosis in LAD segments here. And this is a typical example of ischemic heart disease. And it's relatively straightforward to make a diagnosis, but it's very difficult to make a diagnosis for non-ischemic heart disease because there is so many patterns of the myocardial enhancement. So I'm just going to focus on three parts. One is hypertrophic cardiomyopathy. It's very frequently see is RV insertion point. The next one is mid-wall enhancement in the dilated cardiomyopathy. The third one is sarcoidosis or any inflammatory disease. The LZ is everywhere. So first, I'm going to start with HCM. As a 48 years old gentleman, HCM was diagnosed on echocardiography. So you can see it's LV wall thickening like here. On delayed enhanced image and also perfusion imaging and the corresponding T2-weighted imaging, the significant perfusion defect and also rate gadolinium enhancement and T2-weighted edema. So these types of myocardial damage, we can see it's very frequently in HCM patients. Okay, and again, the stress perfusion is sometimes very effective to identify how much myocardial damage is induced by microvascular dysfunction. It's this type of perfusion defect is probably the microvascular dysfunction due to hypertrophied myocardium. Then in the same patient, the coronary MRI works very well. So we can get very nice coronary MRI image, even as a HCM patient. So to exclude its stress perfusion defect is not attributed to the ischemic heart disease. Its coronary is no significant stenosis. As a perfusion defect may be a microvascular dysfunction due to hypertrophied cardiomyopathy. Okay, this type of LZE in HCM is associated with the poor prognosis of HCM. And there is also a different type of disease expressing LV hypertrophy. And late gadolinium enhancement may help to distinguish HCM, the RV insertion points, the hypertrophy, as a hypertensive heart disease, the LZ is elsewhere, like a lateral wall, and also amyloidosis and diffuse hyperenhancement in the subendocardial wall. So again, as LG is very powerful tool to distinguish myocardial disease. Now I move on to the dilated cardiomyopathy. This patient is a 43 years old patient. It's a history of congestive heart failure. You can see it's a dilated LV, and also it's severely impaired LV, the contractile function. You can appreciate its mid-wall enhancement here in the septum. This mid-wall enhancement is associated with the histology, and upper low is the diffuse fibrosis. So you can see the mid-wall enhancement, but mild fibrosis, you cannot see any mid-wall enhancement. This LZ mid-wall enhancement is a very good tool, and also is a good tool for prognostic information for the dilated cardiomyopathy. I want to emphasize not all DCM patients having the mid-wall enhancement. So probably it's 30% of patients has the mid-wall enhancement. The others don't have any LZ at all. And this LZ information is good for the dilated cardiomyopathy patient for functional recovery after treatment. This is a dramatic process of recovery. The 38 years old patient, so having the severely impaired LV function, you can appreciate this slide. And no LG you can find. After 1 year the treatment, the LV function is dramatically improved from here to the right side. Again, as LG is a very powerful and independent prognosis tool for the dilated cardiomyopathy patients. And I think I want to move on. It's a 64 years old cardiac sarcoidosis patient. It's a sarcoidosis was a systemic inflammatory disease involving eyes and the skin and the lungs. This patient already diagnosed eye and lung as a cardiac sarcoidosis. I want to emphasize patient has a frequent PVC. It's very difficult to get a nice image by cardiac MRI. And we try to get nice image, but you can see it's more the motion artifact. But you can see here it's a very thinning of LV wall. On the LZ image here, you can see it's a high intensity of LZs. You can appreciate around here, especially is the basal septum wall. And that segment is corresponding to the high signal on T2 weighted, as that indicate myocardial edema. And again, it's sometimes cardiac sarcoidosis is very difficult to distinguish the ischemic heart disease. So using the coronary MRI sequence, we can distinguish the sarcoidosis or the ischemic heart disease. And I'm going to move on. It's a future implication of the cardiac MRI. And one thing is a T1 weighted or T1 mapping. The T1 weighted scout image, and we can calculate the T1 quantitatively. Now I'm just briefly showing it's two types of the T1 mapping we can use, the pre-contrast native T1 measurement and also post-contrast the T1 measurement that we call the ECV, the extracellular volume. We use two markers to distinguish the myocardial fibrosis or edema. And using this T1 mapping sequence, and we can calculate its diffuse fibrosis of the aortic stenosis and also diffuse inflammation due to myocarditis. Again, as the T1 mapping is a great tool to detect the diffuse myocardial disease. And lastly, as I'm gonna talk about just a little bit myocardial strain. The myocardial strain has been, it's done so many years. It's the first, it's a group is doing the tagging MRI. And so just measuring is moving of the small tag that calculate the myocardial strain. So you can imagine as this tagging MRI sequence takes more time. And calculating tagging MRI takes more time. It's time consuming and lots of effort we need. But as Toshiba developed, there's a very nice sequence and analysis method for feature tracking. They're based on the cine MRI. We can acquire regular cine MRI and calculate the wall strain to get nice result. I think this is the way to go for myocardial strain imaging. Thank you for your attention.